I'd like to thank the organizers for inviting me to come today. First of all, very impressed by the program. I'm going to stay for the entire conference because I think there's some great topics that are being covered, so I think they really put together an excellent program. And secondly, they did it in a beautiful environment. And so I think that adds another plus. And then I have to say, I'm excited to be able to speak to you. First of all, I want to thank you for being here because I looked outside, and if it were me, I might be thinking about walking around outside on the beach rather than being here listening to some guy who's been practicing for 30 years and probably has strict ideas about things. But the point is, you're the people that makes the treatment of eosinophilic esophagitis work. I can stand in a room and talk to the family, and I can make the diagnosis, and we can decide what we're going to do. But when it comes to diet therapy, you're the people who translate it into the way that helps these families follow it. And I have to say, that's the beauty of working in a multidisciplinary program. We have a gastrointestinal eosinophilic diseases program. We have gastroenterologists, allergists, dietitians, psychosocial clinicians, feeding therapists. We see patients all on one day. And so we communicate with each other immediately. And the fun part of that is I go in the room and I say something, and the dietitian follows me and comes out and says, "Why did you tell him this?" Well, I didn't tell him that. You know, and it's all in translation. Or they'll come, or the dietitian will come to me and say, "You said they were on a milk elimination diet." Well, they're eating 10 different foods that have significant amounts of milk protein. How did that happen? And so those are the sorts of things that, you know, with a multidisciplinary program and that kind of communication, you can make sure that patients are really understanding and doing what you want them to do. The downside is that in an afternoon, that's a long visit. And if I'm the third person in the room, it's like blah, 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 blah. You know, you can just see it's too much information. And so that's why I was really interested in thinking about other ways to get that information across, to reinforce, and think that if we could use social media or those platforms where when I'm sitting down and have a minute, I could just pull that up and have that refreshed every time. If we could do something like that, I think it'd be helpful. So enough for an intro. Today, our goal is I'm going to describe what eosinophilic esophagitis is, how you recognize it, how you manage patients or evaluate patients who have it, and then start with management. And Dr. Venter, that I'm really excited to have as a co-speaker today, is going to tell you how to make it happen. So we're going to start with the case history. This is a 3-year-old boy with eczema, peanut allergy, and asthma. He's not growing well, so he's come to somebody's attention because he's not growing well. He could have also been delivered to parents who were both allergic and delivered by cesarean section and maybe treated with antibiotics early on and then given PPIs. You know, all those things that affect microbiome that we were just talking about in the last lecture. He's not a picky eater, he's a selective eater. I've learned that today, okay? He's a selective eater, I was listening, with a poor appetite and a self-restricted diet. There's certain things he just doesn't want to eat. He'd rather drink than eat, and he won't eat meats or breads. And this is where I love the descriptions the families give. We had a 3-year-old patient who wouldn't eat meat, and when his parents asked him why, he said, "Because it's a hard chew." And I thought, that's a perfect explanation. And then I had another family this week that said they have a 13-year-old boy who has eosinophilic esophagitis, newly diagnosed, and they said, "Oh yeah, he was a slow eater. We used to give him a lot of trouble." We said, "You even have to chew water." And, you know, I mean, those are the sorts of things that just capsulize the whole kind of picture. So this child would rather eat than drink. He won't eat meats or breads because they're hard to swallow. Occasionally chokes and gags and vomits while he's eating, but once he's done vomiting, you clean it up, give him something to drink, he's ready to go again. And he won't try new foods because he's selective and he's afraid of eating new foods. And because he's not gaining weight and he has these other symptoms, and we've been to the doctor a few times, now people are saying, okay, something's up, let's go see the gastroenterologist. The gastroenterologist does an endoscopy. And sure enough, on the biopsies, there's eosinophilic inflammation. Now again, this child sounds like somebody who might have eosinophilic esophagitis. After all, that's the title of the lecture. But what is eosinophilic esophagitis? Well, if you want to write it down, it's chronic immune antigen-mediated esophageal disease characterized clinically by symptoms related to esophageal dysfunction and histologically by eosinophil predominant inflammation. So the point is, it's a clinical pathologic disease. In other words, there's a clinical part, which means you have you have these symptoms that make you think about the esophagus. Have trouble, slow eater. I have trouble swallowing foods, food stick. And then you have to have the pathological part where you actually get tissue and look at it and you see increased numbers of eosinophils. So there's not just one particular test that will tell you this is it. You have to look at the whole picture. And so they developed these diagnostic guidelines in 2011 that have since been changed, and the reason I put them up here again, because it's repetitive, is I wanted to make the point that initially you had to go on a proton pump inhibitor for 6 to 8 weeks at high dose and then get your endoscopy with biopsies and still have eosinophils, or you were called PPI responsive esophageal eosinophilia, PPI-REE. So you didn't have EOE, you had PPI-REE. But then people started looking closer at it, and they realized if you compared PPI-REE to eosinophilic esophagitis, and you looked at some of the major mediators like major basic protein, which is something that deposition in tissues, which is something that eosinophils release into the tissue when they get activated, it was pretty similar between PPI-REE and eosinophilic esophagitis. And if you looked at eotaxin 3, that's a chemotactic factor for eosinophils, it calls them into the area, that was very similar. And if you looked at tryptase levels, which are also an enzyme that's in mast cells, that was pretty similar. And then they looked at the molecular profile and looked at which genes were turned on and which ones were turned off. And if you look at EOE and compare it to PPI-REE before treatment, they look the same. So that got people wondering, well, is PPI-REE really something on its own, or is it just eosinophilic esophagitis? So they got 54 or 53 physicians together, gastroenterologists, allergists, pathologists, about half of them, or a little more, were internists and 21 were pediatricians. And they divided up the world's literature and had everybody review it on different topics, looking at the impact of PPIs and the evidence of the role of PPI in children and adults in assessment of GERD. And then everybody met at a face-to-face meeting at DDW in 2017, that's the group, and they came up with a new diagnostic algorithm. They got 53 physicians, different specialties, to agree on something, okay, that right there, and write it down and sign their name to it. So that is an accomplishment in and of itself. But the new algorithm is clinical presentation suggestive of EOE, and we'll talk about that. You do your biopsy, you determine that they have esophageal eosinophilia, more than 15 eosinophils per high power field, which is about 60 per millimeter squared. Then you rule out the other things that can cause esophageal eosinophilia, and we'll go through those in a minute. And then you have eosinophilic esophagitis if you've done that. Okay, it makes the diagnosis easier. You don't have to do the PPI trial, although PPIs, as we'll talk about, are oftentimes the first form of therapy. Okay? These are all the things that can cause esophageal eosinophilia. The good news is that the majority of them are rare. Okay, you can see them, but they're rare. You have to think about them. But the majority are really reflux disease or eosinophilic gastroenteritis, where other areas are involved. Every now and then we'll see celiac disease or hypereosinophilic syndrome or Crohn's, but again, these are rare. You just have to keep them in the back of your mind. So who gets it? Well, anybody can get it. It's happened with all ethnicities. It's been explained in all ethnicities, on all continents. But the prevalence in the United States is about 1 in 2,000. We're starting to move out of the rare disease category here. We have to be careful because we have funding from the NIH for rare diseases. It tends to happen in males more than females. 75% are male, and a lot of them are Caucasian males. And familial cases are common. And so since it's more common in men, oftentimes it's dad. You know, so the child has it, and then, you know, you start going through things, and if the dad's in the room and say, oh, I do all of that stuff. Well, have you not seen it? No, I don't. Do you want to see somebody have it? No, I don't want to see anybody. You know, it'd be good for your child. That's what I said to the last doctor. I said, you know, it'd be really helpful for your child if we knew if you had it. And he said, well played. You know, his wife's sitting right there. So you have those sorts of things. But the point is, there are familial cases. If you look at the brothers' relative risk ratio, it's about 64-fold increased. And we know that there's both a genetic component and an environmental component, because if we look at monozygotic twins, 58% of them will both have eosinophilic esophagitis. If we look at dizygotic twins, that number falls to 36%, but still, that's significantly more than non-twin siblings, where it's 2.4%. So what that's telling us is that environment also plays a role. And Dr. Venter may say, well, it also has to do with the maternal diet and the things they're both being fed early on, and diet diversity and things like that early on may have a big impact and delivery. The other thing about twins is, you know, that gets me too, is a lot of those kids are delivered by cesarean section as well, which, you know, you wonder about that impact. The other thing about patients with eosinophilic esophagitis is that a number of them have other allergic disease. More than 70% have another allergic disease, which is why I'm here talking to you today as an allergist rather than a gastroenterologist, because it really takes a partnership to take care of the whole patient. We think that allergic disease and not taking care of other allergic disease impacts eosinophilic esophagitis as well, which I'll try to explain that to you, but in a minute. So there are a number of contributing factors. There's heritability. It's mainly in Caucasians, but it can be found in other ethnicities. There's a high relative risk among family members. Gender plays a role. It's mostly males. There are environmental factors, cesarean birth, antibiotics, formula use, and then atopy plays a role. There's some patients that get worse during their pollen season. So there are all these different, and they're genetic variants. There are all these different things that come into play that are important. So what are the triggers? Well, there are food allergens, airborne allergens, and other allergens. And it makes sense that foods would be a trigger because this is a disease of the esophagus, and when you think about what the esophagus is for, it's really a tube to carry food from your mouth to your stomach after you've chewed it up. So think about it. You know, you take a food, you chew it up, you get it in saliva, you get it in digestive enzymes, you get it where it's all gooey, and then you swallow it so that it can come into contact with the lining of your esophagus as you swallow it. And you swallow, you know, you eat large amounts of foods. What do you think the weight an average American, of food an average American eats a year? Anybody got any ideas? We're going in pounds, huh? Somebody said a ton. Ding, 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 ding. Yes, it's a ton. They've looked at it. And I find that interesting. And if you look through further, it's about 20.4 gallons of milk and about 53 pounds of bread. And just to improve your appetite for lunch, you swallow 547.5 liters of saliva a year. So take a big swallow. And I'm going to improve your appetite more in just a minute. So which foods tend to trigger eosinophilic esophagitis? Well, it's interesting, but if you look at the foods, they're the same foods that trigger IgE-mediated disease, and we'll talk about that. And that's how they got found out early on, is people just said, you know, gastroenterologists said, well, I'm going to treat these people. I want to take we'll just take the common allergens out of their diet, you know, milk, egg, wheat, soy, peanut, tree nuts, fish, shellfish, and sure enough, a good number of people got better on that diet. But anyway, milk is responsible in about 2/3 of the patients, egg and wheat in another quarter of patients, and there are geographic and age differences. In children, it's milk, egg, and wheat. In adults in the United States, it's more milk and wheat. In Spain, they see more legumes. This may have to do with introduction of legumes or when they're introduced into the diet or how much they see. And soy is also a cause in the United States. And then peanuts, tree nuts, fish, and shellfish are less common. So when we start thinking about diets, when we think about the four-food, it's milk, egg, wheat, soy. So if you look at the number of foods driving disease, in about 1/3 to 50%, it's just one food. Oftentimes that's milk. In about 30%, it's two foods that drive disease, and in the other 30%, it's 3 or more trigger foods. Now, I'm in a referral center, and so we tend to see more difficult patients. And so for us, it's, the ones that respond to a milk elimination diet have usually been taken out of the picture before they come to see us. So I have a skewed view, but that's helpful to know. Now, the other thing that people sometimes disregard is the impact of other allergic disease on eosinophilic esophagitis. And I just want to make the point that if you look at this nose here, you can appreciate the clear secretions, again, working on your appetite. And then this is somebody who's having an allergic reaction with nasal congestion. So nasal congestion and rhinorrhea. This is allergic rhinitis. And if you could take that mucus and stain it with Hansel stain, this is what you'd see. It's full of eosinophils. So people who have seasonal allergic rhinitis or have significant perennial allergic rhinitis, they have eosinophils in their nasal mucus on a regular basis. And what do you do with everything that's in your nose? You blow it out, right? No, you swallow it. You swallow it because you're upright, it just drips down the back of your throat and you're swallowing that all day long. You may blow it out when you get up in the morning, but all day long you swallow it. So my point is that those eosinophils got in the nose because they're responding to mediators that are probably still in nasal mucus, and you're swallowing eosinophils all day long. So it would make sense to treat allergic rhinitis aggressively in children who have significant eosinophilic esophagitis. And this is a proof of concept. It's just one patient presented by Dr. Spergel. This is a 21-year-old woman who was allergic, and when they looked at her endoscopies in and out of her pollen season, so during pollen season, large numbers of eosinophils, but in the middle of the winter when nothing's pollinating, nothing, back again the next season, high numbers of eosinophils and back down out of her pollen season. So the point is, we need to think about the potential for aeroallergens and other allergens that are inhaled and then swallowed, even though it's a much smaller amount, to play a role in eosinophilic esophagitis. There's also a thing called a pollen food allergy syndrome. So, who in here is allergic to ragweed? Okay. How many of you, when you eat bananas or melons, they make your mouth itch? Yes, we have a couple. See, this is a way, as allergists, we like to play around. We like to freak people out. So when I get somebody who has a big positive skin test to ragweed, I say, I bet your mouth itches when you eat melons and banana. And they go, how did you know that? You know, it's just one of those little sneaky things you can do. But it's a well-known entity. So basically, in the pollen food allergy syndrome, you become sensitized to the pollen, not to food. But the food has antigens or allergens that cross-react with the allergens in pollen. So when you eat the food, you get oropharyngeal tingling and burning, and maybe your throat feels a little bit full as well. Anaphylaxis is rare in this entity because these antigens tend to be rapidly digested when they hit your stomach. So you may get oropharyngeal symptoms, but when they get into your stomach, they get digested quickly. You don't absorb enough to have an anaphylactic event, although anywhere from 2 to 10% of patients with pollen food allergy syndrome can have systemic reactions. So it's a really interesting entity. And you can see on the right, that's ragweed. And then birch pollen is on the left. It cross-reacts with hazelnuts and apples and some other foods. So these are patients who have allergic rhinitis to a pollen that then when they eat a particular food have oropharyngeal symptoms. I want to take just a minute to talk about the oral allergy syndrome, the definition of which is kind of changing. It used to be used for pollen food allergy syndrome and is often used interchangeably. But now they're saying that it should be referring only to reactions where the oropharyngeal cavity is involved and nothing else, but that's kind of a slippery slope, if you will. The point I want to make from this slide, which I'm sure you can't read, so I could pretty much say anything at this point, is they took a group of patients with eosinophilic esophagitis and they took a group of patients that had allergic rhinitis. And if you come down to here and look at the percentage of patients who have pollen food allergy syndrome that are pollen sensitized, if you look at the patients with eosinophilic esophagitis, the ones who are sensitized, 50% of them have pollen food allergy syndrome. If you take just people who have allergic rhinitis and are sensitized as a group, only about 10%. So the incidence of pollen food allergy syndrome in patients with EOE is much higher than patients with allergic rhinitis alone. And the point I'm trying to make here is that everybody says it's not an IgE-mediated disease and want to discount IgE altogether. My point is that you have to keep that in mind because there are times where it may play a significant role, and that's why you need to be looking at these patients with testing. So what are the symptoms? Well, they tend to vary as you get older because as you get older you can describe things a little bit better. So infants often have feeding aversion or feeding intolerance. They don't grow, and that's what tends to get people's attention. One of the things about children is they can't tell you what's going on, so they just show you. They just barf. And so they're not, they're having trouble, they vomit, and they can't tell you, I feel nauseated. So you don't pick up nausea in kids, but you pick up the vomiting. As they get older, they'll tell you they have epigastric pain or chest pain, they have trouble swallowing, or in the worst case scenario, they have a food impaction. And it's not uncommon for some of these adolescents who have it to get Heimlich maneuvers performed because they're trying to get a food up they can't get up. And sometimes that's what brings them to medical attention as they show up in the emergency room. So food impaction is actually a common presenting symptom of eosinophilic esophagitis. This is just a prospective study with 33 adults that were seen in the emergency room with food impaction over 3 years, and 50% of them had eosinophilic esophagitis. They just have a stricture, can't get the food down, and it stays down. They show up in the emergency room. So these are all the questions I didn't ask for the first 20 years of my career because I didn't know about eosinophilic esophagitis. And the bridge question is, does your child eat slower than everybody else? And if you get a hit on that, there are lots of other questions that follow up. And the point is, these kids, I mean, think about it. If you couldn't swallow a food, what would you do? I mean, it's amazing what these kids do to compensate, which is why they don't get picked up, because they're compensating on their own. So they take, they avoid certain foods like meats and bread, but if they have to eat them, they'll take a small bite, they'll put ketchup or ranch dressing all over it, they'll chew, 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 and then they'll drink a lot of liquid to get it to go down, because they're trying to get it through a smaller hole than, those of us who have a normal esophagus. But people don't pick that up. They think they're there. They just oftentimes kid them about, it takes you so long to eat. Oh my gosh, you're the slowest one, you're never finished. And then, of course, when they find out they have eosinophilic esophagitis, we all feel bad. The other thing that gets me is it gets to the point where he won't swallow it. He chipmunks. He chews it up, puts it in his cheeks, walks around for hours, and then spits it out. Or he swallows it a small amount at a time. So these are all behaviors that you think, yeah, something's up here, but we don't think about because we're not, we don't know about eosinophilic esophagitis. So what are the other things that will turn you on to it? Well, if there's a family history of severe GERD, grandpa can't swallow, dad can't swallow, and if there's a family history of allergic disease, or if the child has other allergic disease, there's this thing called the atopic march. And so basically you inherit the genes to become allergic, and these kids often present with eczema first, or food allergy, and then they develop the other one, and then they wheeze with viral illness, and then they get allergic nasal symptoms because they've had several seasons of pollen exposure, and then some of them get eosinophilic esophagitis in there. So we think that eosinophilic esophagitis is actually part of the atopic march. Oh, and I want to just go back here for a second because I've already shown you, by the way, I'm embarrassed to say this is my son's nose, who's quick to tell everybody his dad's an allergist and doesn't take care of him. This is a child who's actually in the middle of a reaction to a food challenge with nasal symptoms, congestion. These are excellent pictures of eczema, significant eczema. This is a molluscum lesion, which is more common in kids. It's a viral wart that's more common in kids who have atopic disease. These are Denny's lines that everybody talks about, edema of the lower lids. This is a woman who is a sous chef, and she has angioedema of her eye here because she was just slicing carrots and her eye itched and she reached up to touch it and developed angioedema. These are the dark shiners that are really due to nasal congestion. They call them allergic shiners. So all these kids get diagnosed as being allergic that aren't really allergic, but they have nasal congestion for other reasons. And then this is a transverse nasal crease. This is what helps me with a teenager who says, what do you mean? I don't have allergic rhinitis, I feel fine. My nose is just fine, And I look and he's got this big nasal crease from doing the allergic salute over and over and over to the point that he's got a crease. So when they say, I may say, I don't have any of this, I don't have rhinitis, or I don't have rhinitis, I say, well, that's funny, but your nose says you're lying. Anyway, it's just kind of the fun stuff. So what does it look like? So if you get a tube and look down their throat, which is what an endoscopy is, you'd see these things. You'd see the furrows, the linear furrows here. It's not normal. Okay, whoops, let me go back, whoops. See the linear furrows. You'd see these exudates, and sometimes they're nodular like that, and sometimes they're more expansive. And if you were able to, take one of those off and put it under a microscope, it's full of eosinophils, which makes me think that the cell that's causing them to come in and activating things is probably on the epithelial end, because why would they migrate all the way through into the lumen unless one of the signals was coming from an epithelial cell or something on that end? And then these are the rings that you can see after they've had disease for a while. Okay. These are just more. This is what a normal esophagus would look like. I think you can appreciate, you can see the blood vessels. There's not too much edema. You don't see any furrows or rings. Now you see the white exudate. Then you can see the rings here, more rings and furrows. And then now you see a stricture where it's narrowed. And then this is what it looks like. That makes my chest hurt just to look at it, after you've been dilated, or sometimes just after you've passed the scope. They say they have crepe tissue mucosa in the lining of their esophagus. It pops because they've got fibrosis. It's interesting. I would think no one would want to have a dilation after looking at that. It's like, why, how can they get anybody to come back in for another dilation? But the point is they have pain for about 24 to 48 hours, and they can swallow so much better that they're ready to go. It's like, oh yeah, I would do that again in a heartbeat. So it's really, and it's not dangerous. We'll talk about that. So what are the endoscopic findings? Well, if you have them swallow barium, you can see things like this. I think you can appreciate the esophageal stricture there. It's much smaller because, again, you have inflammation for a long period of time that leads to fibrosis and scarring, and then people can't swallow. Their esophagus doesn't work right. This is a 32-year-old woman with a lifelong history of dysphagia. It took hours to eat, and they thought she had GERD and hysteria because they didn't know about eosinophilic esophagitis. And again, you can appreciate the stricture. This is long segment esophageal narrowing, and this is the stuff that scares me to death. It's like that's a long way to dilate, and you can understand these patients have trouble maintaining nutrition. That's what we're trying to prevent. So what are the diagnostic clues and cautions? People who have IgE-mediated allergies to foods and go on oral immunotherapy are people who are being treated with SLIT for allergic rhinitis. Again, they're swallowing something they're allergic to on a regular basis, and a small percentage, not the majority, can go on to develop eosinophilic esophagitis. So now, well, we'll talk more about it. You also need to think about, well, so now when I have kids that outgrow their food allergies and we put the food back in their diet, I tell them, look, if you start having trouble swallowing, or tell the mom if the appetite drops off, you notice they're refusing certain foods, we got to think about eosinophilic esophagitis because some patients who have IgE-mediated food allergy, when you add the food back in, they develop EOE. You got to think about a pre-treated mucosa. So we've got a lot of patients that are using inhaled topical steroids, but maybe swallowing a large dose, particularly if they don't use a spacer, or they may be using a topical nasal steroid spray. Again, they're swallowing that might impact it. If they've had a normal endoscopy before, it doesn't mean they haven't developed EOE now. And they can have a normal looking esophagus, but if you biopsy it, you can see eosinophils in the tissue. So now gastroenterologists know now that even if it looks normal, you're going to take pieces of tissue. And the pediatric gastroenterologists tend to do that, but adult gastroenterologists oftentimes would look and say, well, it looks good to me. I don't need to biopsy that. It's just added cost and isn't going to help. But you have to take a look. You have to take multiple biopsies. And if they have an abnormal endoscopy and histology, that's not diagnostic. You have to have the clinical signs and other findings as well. The other thing is that when you take a piece of tissue, you're taking really 0.01% perhaps of the surface area of the esophagus. So, and this is a patchy disease, so that's why you have to take several biopsies to find it. So we get upper, mid, and lower, a couple at each spot. And if you looked at it under a microscope with appropriate staining, what would you see then? Well, it's more than just increased eosinophils numbers, although that's what you see. We're looking at a eosinophilic abscess here. And you can see increased numbers of eosinophils throughout this. But you also see basal zone hyperplasia. You see dilated intercellular spaces. You can appreciate in here, those open spaces. You can see the eosinophilic abscess, and then sometimes you'll get superficial layering here along the top. And this again shows isolated eosinophils. This shows, you can see the areas between the cells that are larger than they should be. You can see basal hyperplasia here. This shouldn't be expanded out that far. And this is just what we call a radipeg or papillary elongation to provide nutrition to the area because it's hyperplastic. So there are other signs that go along with this. Now, the reason we want to treat it in kids and adults is because if you don't do anything and they have chronic inflammation, it leads to scarring. They can't turn it off. And so this is a study that we wouldn't do today because we know that people develop scarring, so we try to treat people. But Alex Straumann, who is a gastroenterologist in Switzerland and really brought this to the forefront, even though people told him it wasn't an entity, he stuck with it and really brought this to the forefront, showed in following people who were not treated that over time you can see that this black is fibrosis. So they go on to become fibrotic. The good news is that even if they have fibrosis, you can treat them with anti-inflammatories and swallow topical steroids, and they can improve significantly. So what are the complications? Feeding dysfunction, malnutrition, failure to thrive. They can get an esophageal stricture. They can get an impaction. But cancer isn't part of this, and so we always tell people that because they're always worried they might develop cancer. I do tell adults that if you're having trouble swallowing, you could have cancer. You should really go get that checked out because it may be EOE, but it could be worse, and so you really need to have somebody take a look. So do you outgrow it? Well, unfortunately, the data we have to date says that very few people outgrow it. This is just a study from Jonathan Spergel's group and Melanie Ruffner. They looked at 1,812 kids in their database and were very careful about how they defined it. And only 9 out of 1,812 had outgrown it over a period of about 8 years. So again, this tends to be lifelong, and so that's why we try to keep in contact with our patients. And the ones who said, look, those guys are crazy, I don't have this, I don't feel anything, I don't want to do this, and drift off, we tend to see them in a couple of years with food impaction again. So how do you work these people up? Well, you look for the symptoms that we talked about, you look for the other things that go along with it, the comorbidities, and then if they're having trouble swallowing, you may want to get an esophagram, because if they have a stricture, you want to be ready to do a dilation. And you want to know if you're going to need to do that before you put them under. And then you get your endoscopy with biopsies, and you look for eosinophil in their esophagus at a certain number, and you evaluate for the disorders that are not EOE, and if they have findings consistent with GERD or whatever, you treat that, and then you follow them up and monitor their clinical course. But then there's the group that has the findings consistent with EOE after you do all this, and the treatments are the 3 Ds, diet, drugs, and dilation. And I'm going to leave most of the diets to Dr. Venter, but I do want to talk a little bit about the tailored targeted diet. The drugs we use are PPIs, or swallowed topical steroids, and dilation is something we talked about a minute ago. So what about allergy tests for EOE? So a lot of people say this is not an IgE-mediated disease. Why are you even doing allergy tests? They're not helpful, they're not predictive. You're costing the patient money, et cetera, et cetera. And they're right, EOE is not an IgE-mediated disease, but that doesn't mean IgE doesn't play a role on some level in some patients. And we can talk more about that if you'd like. Skin tests and serum IgE tests are effective for diagnosing IgE-mediated allergy. So if you have peanut allergy, you eat a peanut, in a few minutes you get hives, your mouth and throat feel weird, your stomach starts to hurt, your nose runs, you sneeze, you have difficulty breathing, you barf, you drop your blood pressure. Those sorts of things that are IgE-mediated, typical allergies, skin tests and serum IgE tests are perfect for diagnosing those. But again, EOE is more than that, so you can have noise in the system. You don't want to take every food out of their diet just because they have a positive skin test. And they can also have a negative skin test to a food like milk, and that can still be the driver. So you have to be careful. So these tests are not reliable, but they can provide helpful information. For example, a number of the patients with eosinophilic esophagitis have IgE-mediated food allergy, and a larger number of them have allergic rhinitis, and we talked about how allergic rhinitis might play a role. And this is just a study showing that the prevalence of eosinophilic esophagitis is higher in pediatric patients with IgE-mediated food allergy. In the interest of time, I'm going to share they looked at a large number of records. They found over 13,000 patients with a food allergy. 836 had a diagnosis of eosinophilic esophagitis, and of that 836, 266 had EOE alone, and 570 had both EOE and IgE-mediated allergy. So again, in the general population, the incidence of EOE is 0.0004, 4 in 10,000, and it's 100-fold higher in the group with IgE-mediated food allergies. So we want to think about that in kids who have other food allergies. And then there's this interplay between IgE-mediated disease and eosinophilic esophagitis. Like I mentioned to you, patients on oral immunotherapy to different foods, there's a small percentage, not the majority, who will go on to develop EOE. And then there are patients who've outgrown their food allergy that after addition of that food to their diet will go on to develop EOE. And then in the other direction, we have patients with eosinophilic esophagitis where you take milk out of their diet, and then when you try to reintroduce it in a few months, they have an allergic reaction because they become sensitized, or they were sensitized before but tolerized because they were eating milk on a regular basis. So you need to think about those things in taking care of these patients. So what is the role of allergy tests? Well, if you think they have IgE-mediated food allergy, slam dunk. If the empiric elimination diets aren't working, you might think, well, I'm going to get more information of foods I might want to take out next by looking at skin test data. I think you want to do it before you remove a common food allergen from the diet, because I want to know before I take them off of milk or egg or wheat or soy whether they're sensitized to that, because then I can tell the parents, look, you want to be careful that they don't just sit down and eat a bowl of ice cream or macaroni and cheese in a few weeks here. We could have a problem. And then I want to look at it again before reintroduction of these common allergens into the diet, because I want to make sure in the meantime that they haven't become sensitized. And, you know, I don't say, go home and eat some milk and call me on your way to the emergency room. You know, I don't want to get there. So, and then if they have environmental allergies, we want to know which allergens they're allergic to. We want to treat their allergic rhinitis aggressively. And we want to think about what time of year they might actually get worse, and that might also help us decide when we do an endoscopy. Why would you take a child who has horrible grass pollen allergy and do their endoscopy right in the middle of their grass pollen season? Or if you do it, you at least need to factor that in. And so we also want to take care of other allergic disease. So we talk about medications. PPIs, again, is just high dose for 6 to 8 weeks because they have some anti-inflammatory effects. We also, and there's about 40% of the population that will respond to PPI alone. We have topical steroid treatments. We tend to use either budesonide mixed in something like honey or Splenda and have them swallow that. Or we use a meter dose inhaler used for asthma. They squirt it in the back of their throat. They do not breathe in. When they squirt it in the back of their throat, they swallow. They don't eat or drink for 30 minutes so you can coat the esophagus. And these forms of therapy are very effective. Dilation is for the patients who aren't responding or have significant stricture, and risk of rupture is really small, so that's good to know. A lot of the patients remain symptom-free for a year, and about 40% will remain symptom-free for a couple of years, but they need close follow-up because that determines them or shows that they're a group that has the ability to develop strictures. And it's not recommended as monotherapy because they'll have inflammation that you're not taking care of and they'll stricture again or get worse. And with that, I'm going to pass the microphone to Dr. Venter, who's going to talk about how you translate the diets into taking care of these patients. Thank you very much.
Are you gonna? Right. So I also would like to thank the organizers for inviting me to present with Dan Atkins today. 20 years ago, almost up to the day, I started my PhD on a small island in England. And there was only one paper published on how to perform food challenges in children with food allergies, and Dan Atkins was one of the co-authors. So he has been directing my whole life to some extent, and we've now been colleagues for 2.5 years, but this is the first time ever we get to present together, so it's great. And it's a great program, but other than Dan, I will not be staying. I've been doing a lot of traveling, and when I did make a special appearance at home on Tuesday, even the dog ignored me. So I think it's time to go home, but I'm very happy to be here. So we will be talking about witch elimination diet today. You've got all my disclosures there. Some of them are relevant because in the next few slides I will be talking about the elemental diet. So we will look at the dietary approaches for the management of EOE, and I was just saying to Dan, and I've been tweeting all morning because there's another food allergy meeting going on, and so all my Twitter buddies are tweeting about the microbiome and the complexities of the food avoidance diets. And I'm not saying that they are not complex, but I have never seen anything in my life than what I've just heard about the management of Crohn's disease. So I said to Dan, if we have poor compliance, perhaps we should send them to the GI clinic and say, you know, I'm sure they'd be happy to come back to us. But what I do have to say, perhaps the difference is that in our patients, it's for life. And there's no way out, whereas perhaps with Crohn's disease there is the intensive treatment and then some relaxation, although I've not seen anybody with Crohn's for 20 years. So then discuss nutritional and growth implications, and then also explore the nutrition conversation. So as Dr. Atkins already said, we have 3 dietary approaches. It's the elemental diet, it's the test-directed diet, and it's the empiric elimination diet. So this paper has just been published. I did the paper with Kiran Atwal. I don't know if there's anybody from Nutricia in the audience, but Kiran works for Nutricia in the United Kingdom. She's a young dietitian. I got no money for this publication, But she addressed some really important things in the paper which I think we've previously omitted from other review papers in EOE. But the message I want you to take from this is the black bar is before treatment in all the cases, and then the white bar is after treatment. Diets work, okay? They may work to a different extent, but they work, because there's always quite a large proportion of patients who will start, and I am going to refer to 15 eosinophils per heart power field a few times, but as Dr. Atkins have clearly showed you, it's a bigger picture. That's why you need the gastroenterologist. It's not just counting eosinophils. It's really what do you see, what's going on there in the esophagus. So you can see large proportion of patients with eosinophils above 15 at the start of the trial, and then the reduction. So this was targeted elimination diet, so they had testing. This is the empiric elimination diet, where we have the discussion with the family to say, do you want to go on a 1 food, 4 food, 6 food exclusion diet? And then this is a combined intervention, which is the targeted elimination, empiric, and elemental diet. So they work. That is the message you can take. In terms of the elemental diets, they work even better than the empiric and the test-directed diet if you can get the patients to adhere. Because they basically take only an elemental formula. In some places they would allow them to have apples or perhaps blueberries or spinach alongside that. But for the most of it, they're going to be drinking the elemental diet. So this is the first ever case series reported in 1994 by the Mount Sinai group. And then we have the Markowitz trial, Liakuras, Kagavala, and Henderson. So these are all pediatric trials from all over the United States, showing that almost 100% of patients get better, but definitely 90% of cases will have complete resolution of their EOE on an elemental diet. Now, the interesting thing is, I'll show you on, let me first get you to vote and then I'll say, what percentage of children do you think are likely to improve on a 1 food elimination diet? So you have a kid with EOE in front of you, you decide you're going to do for just milk exclusion. What percentage of children will get better, will have a resolution on just milk exclusion? So I'm going to ask you just to by show of hands. 40 to 60%? Over 80%? 10 to 25%? More than 90%? So the correct answer is 40 to 60%. So you know, if you have a family that's really not into steroid therapy, but they also really cannot get their heads around a 6 food or a 4 food elimination diet, it's perhaps worth starting with a milk elimination diet, particularly as we often see with kids, they can't swallow, they have tummy aches, so what do? They drink milk and they eat yogurt. And if you're lucky, they have cheese strings on top of that, because it's something that can go down. And so if it's a kid with that kind of diet history, you'd likely, perhaps even more likely than 60%, that the kid may improve just on milk exclusion only. So this is a summary of all the diet trials we have in EOE. So here I have to stand up for the EOE world. We haven't got a lot of diet trials. And yes, you know, you can poke holes in every single one of them that we have. But what these trials show us is they're hard to do, but if you can do it, they work. They may have work in different extent, but they're not all bad and they don't all work. And I'm very conscious, I really want to say this because I have to hear this many times when you speak to pure statisticians. Now, here you can see that 2 trials we had up to about a month ago in the United States showed us that about 65% of kids will improve on a milk-free diet. And here we got, and I can blame Dr. Atkins now because he's one of the co-authors on the study, that showed only 44% of kids got better on a milk exclusion diet, which is a multi-center trial in the States. So it sort of like dampened our hopes a little bit, but I think there's still many things they need to look at. Perhaps, you know, the pathologist in this 44% trial, you know, with the top-notch pathologist, and perhaps they had a little bit stricter criteria than in previous trials. Who knows? But then you get the 2 food elimination diet. You would have expected that to be higher than 1 food, but we're still about 43 to 44%, which is done in Spain and one in the, actually the 2 food was only so far done in Spain. It's milk and wheat. Then we have the 4 food. Again, we start about 44 to 64%. So you can see there's not that big a difference between 1 food and 4 food, but I think it's still safe to say we're probably luckier with a 4 food, and then gradually the success rate increase as we get to the 6 food exclusion diet. So I think, you know, the message you can have with the family is, why don't we start with 1 food if you're really reluctant to do a 6 food? But 6 food is going to give you that little bit more of a chance to improve. So perhaps if you'd rather just cut all 6 out and then reintroduce them 1 at a time, then that's a safe approach too. As Dr. Atkins already said, 6 food is milk, egg, wheat, soy, all seafoods and all nuts. We've really got only a few case reports, particularly in children who responded to peanut or nut avoidance or seafood avoidance in EOE. So again, you know, if it's the big decision for the family to make between 4 food and 6 food, and this happens to be a kid that likes to eat, I don't know, deep fried calamari once a month, then perhaps we could do 4 food first. You know, you get all sorts. But this is why this is not just a textbook situation where we can decide this is the diet. We have to sit with the family and see what works for them. Why is the data so confusing? So, well, first of all, when we look at what milk exclusion mean in all the different trials, and I just summarized a few, thankfully they all excluded milk, and we don't allow sheep and ewes milk. Then when it was egg avoidance, it's just egg across the border. Now, my dad grew up in an area in South Africa where there's a lot of ostriches. And so I find it fascinating. My dad's the only person I know who, when you ask, what do you want for breakfast, he'd say a chicken egg. Because obviously where he grew up, there was a big difference between eating ostrich eggs and chicken eggs. But for the most of it, you know, it's just egg avoidance. Then here comes the issue with wheat. Every time I give a talk on EOE, the dietitians want to know, do you do just wheat exclusion or do you avoid all gluten-containing grains? See my, I've got a nice crease here because I haven't taken my antihistamines this morning. And so the wheat exclusion is normally in Europe. We actually published a paper to show that. In Europe, we do, or when I used to be there, milk, wheat, barley and rye. In the States, they say that they only do wheat only. But this study that I said Dr. Atkins was part of, I started with the setup of the trial and then I left. But they have very good diary data to actually see whether those in the States on a wheat exclusion do eat rye and barley. Because I bet my life they don't. And even though we say that we do only wheat exclusion, it's probably rye and barley exclusion too. Although at the time I was in Cincinnati and I did my best. Gave these patients recipes to bake rye breads. I showed them how to order the real German rye breads on Amazon. It wasn't going to float. Whereas my colleague who works at Mount Sinai in New York says, my patients come in and they eat rye bread already. So I think it also depends on where you live. Again, with the legumes, it's a bit messy. In the States, it's usually just soy avoidance. In Europe, because we have a lot of the pollen food allergy syndrome, we avoid the soy plus the peanuts and other legumes. In one of the studies by Alfredo Lucendo in Spain, where they have a lot of fruit and vegetable allergies, they also told people to avoid anything that makes them mouth itch alongside the other 6 foods. And then here comes the may contain thing in. Getting back to the Crohn's disease talk we had previously. Now the fascinating thing is that nobody get the success rate in the EOE trials as Alfredo Lucendo. If you speak to Lucendo, he says in his papers, I tell them to avoid packaged food and things that may contain traces of allergens. But the truth is, they go home and cook. And so you wonder whether they're just not eating any of these emulsifiers we've been talking about. Because, you know, I spend lots of time in speaker rooms uploading slides. And so then I take my chances to ask all these very important people in the world questions. And then you will say to you, I don't have a dietitian. I haven't got time to discuss label reading with them. They live in Spain, they have beautiful fruit and veg, and everybody can cook. So I think that may also explain why we see such differences. Then this is a paper I did with Antonella Chianferoni from the CHOP group, showing just really that in pediatric population, like Dr. Atkins said, and I've already showed you, milk tends to be the number one trigger, and then it's followed by wheat or egg, depending on which study. So if you really want a family that can say, I can only do 2 foods, perhaps in some cases you may want to do milk and egg, in some cases perhaps milk and wheat. Again, this is where the allergies come in, because if this is a kid with ragweed allergy or some other tree pollen allergies with positive sensitization to wheat, that may skew your answer about whether you're going to do milk and wheat or milk and egg. The other thing, and this is why I left it here, this is an adult study from a good friend of mine and dietitian in the Netherlands, where they put adults on a test-directed diet, really. But the point I want to make from this study is, bringing me back to Crohn's disease, is they got a few of the adults better, but really the success rate was low. But the fascinating thing was that they were unable to identify foods in 3 adults. So they put them on the elimination diet, they got better, they introduced every single thing they've taken out, and they were still fine. And so you wonder whether, similar to gut rest, as we see in IBD, perhaps some esophageal rest is just what some people need as well. So that can happen too. But milk, definitely the number one food. So which dietary treatment? Again, this is a discussion that the allergists and the gastroenterologists normally have with the families. Sometimes the dietitian may come in as well. The elemental diet will work. You can categorically say that. I'm not going to go through every point by point, but what I do want to say about the elemental diet is, and like Dr. Atkins already said, in the tertiary centers we probably see the worst of the worst. This kid is 6 years old. He's had tummy ache all his life. Everything he eats comes back up in his mouth. You put them on an elemental diet, the tummy ache goes, he feels well, he's growing. Mom is not nagging at dinner table that he has to eat. Do you think they want to introduce foods? So as much as it can be really hard to get good compliance in some cases, in other cases, this is the magic in the bottle they've always wanted. And if you don't actively and progressively introduce foods, I promise you, you're going to end up in tertiary centers where I've seen 18-year-olds who suck on honey alongside their elemental formula because they've just not reintroduced foods for over 11 years. And now you've totally lost all chances. You've gone way beyond selective eating. And that is the time. So often in allergy clinic, I think, I'm pleased I'm just the dietitian and not the allergist, but there's also many times when I think, I'm so pleased I'm not the feeding therapist because I have no idea where we go from here. So really, if they get better, get the foods back. There's a big problem. We have not got reintroduction protocols or standardized reintroduction protocols in EOE. But I would say after an elemental diet, don't mess around with just apple and just melon and just whatever. In some cases, you may want to do some fruit and vegetables individually, but for the most of it, you're probably okay doing groups of fruits, like get the citrus fruits in, then let's do the melons, then let's do all the vegetables together, depending on the situation, but really get the foods back. Empiric elimination diet, it's easier to manage than elemental. We have specific foods we're taking out, so we've got fewer foods that we have to put back. And then skin testing directed diets. Again, the guidelines are against these, but I'm totally with Dr. Atkins on this. The skin test directed diet, it gives you a picture of the whole patient. It tells you how careful you should be about taking things out, which perhaps they could develop IgE-mediated allergies too. And it also helps us to determine which foods we're going to introduce first and last. But that's very individual for every family. Then, of course, as a dietitian, and my passion in life, or my real interest in life, is diet diversity and how that affects, microbial diversity in the gut. And what I keep saying to allergists and is that, allergens don't exist in isolation. Like, for example, who's not heard that we have to give peanuts to babies early? in the first year of life. We should not be avoiding peanuts anymore. But my daughter is now 14, just to give you an idea how long science takes to get around. I was about a week off giving birth to her when George Tutui, the first author of the LEAP study, called me and said, we've just submitted a grant to do the study. And I said to him, and thankfully I was completely wrong, I said, it's going to be a disaster, okay? Because they're not going to eat the peanut, they're all going to have anaphylaxis, and you have to remember peanuts don't exist in isolation. You're going to make them fat because you're going to give them a lot of protein and a lot of fat, and they're not going to eat their fruit and veg. But in the wisdom, George listened to me, and they had very intensive dietetic input in this peanut trial. So you have to remember it worked, but the kids in the active arm had much healthier diets. They didn't eat cookies, and they didn't eat chips or crisps, as we call it in the United Kingdom. So there's also the arm of perhaps we have manipulated the microbiome of these kids eating peanuts. But when we take allergens out or when we put allergens in, we have to remember with that peanut protein or that milk protein you take out, there comes nutrients, there comes fiber, there may be prebiotics, and they have an immunomodulatory effect outside of just focusing on the allergens we're eating or avoiding. So the most likely nutrient deficiency in an individual excluding milk and seafood is magnesium, omega-3 fatty acids, iodine, zinc, fat. It's iodine. When we put these babies on the 6-food elimination diet and we take, or the young children, and we take milk and fish out of their diets, there's almost no source of iodine left, okay? So in the United Kingdom, even though they contain emulsifiers and may be bad, all these milks like the oat milk and the almond milk and the pea milk now comes fortified with iodine. We haven't done it in the US yet. So an important question for dietitians is, do you cook with kosher salt? Because kosher salt, of course, is now the new, buzzword, but it's not fortified with iodine. And in these families in particular, you may want to think about iodine fortification. Then I'm not going to go through all of this. We have a huge group of dietitians in the audience, but we need to know which nutrients are in each of these allergens, and we need to know how to substitute these foods. Now, fascinating also that you've got quinoa on your CD-ED diet. And I've just been to a presentation in Europe where they've done studies showing that in a murine model, quinoa destroys the gut epithelial layer in infants, in mouse. I have to say this, in mice, in infants. It was destroying it. So, but quinoa is one of our staple foods in the EOE world too. And so I think, the verdict is out whether it's a good or a bad thing to eat. But from a nutritional point of view, it's a high protein wheat-free grain, and it also has iron in. So the other point I want to make is that people often think that all children with EOE and food allergies are malnourished, and that's not really the case. This is data from the group in Colorado. And here you can see that when the EOE group, without seeing a dietitian, had slightly less protein intake, but it wasn't really worrying, and they had slightly less calcium intake, but the other nutrients was fine. So I don't have a case today because I haven't got time, but normally the cases will come in, and I'm interested about that calcium, but there are calcium supplements, vitamin C, they always have some echinacea in there too. And then if you're lucky, you have a bit of omega-3. So look at what they're supplementing with already before you just get concerned about nutritional deficiencies. This is the other thing as a dietitian that I struggle with in an EOE clinic. So if a child has symptoms, particularly feeding issues, taking more foods out are likely to resolve the feeding issues. True or false? So the mom comes in, kid's gone on 6-food elimination diet, and she says, I think we need to take something out. The kid's still got tummy ache all the time. It's definitely another food. Would you just immediately take another food out, or would you think, well, perhaps this is not the case? Okay, so it's usually not the case. Oh, now it's gone all upside down. But what this was showing you, you can sit like this, is that quite often and in some cases, not perhaps that often, but in some cases it's only 2 out of 42, we get the eosinophils down to 0 even. The esophagus look beautiful. They still have tummy ache. Why? Because they've had tummy ache all their lives. So they still have to get their heads around the fact that they now don't have tummy ache. So just being symptomatic, it's not necessarily, if the gastroenterologist is happy and the allergist is happy, but we're still dealing with some feeding issues, it's not reason to take any other foods out. And you have to remember that a lot of these kids have learned feeding behaviors. Once again, you know, the eosinophils may be gone, the esophagus may look beautiful, they still want to have that glass of water next to their mealtime because they've just done it for 10 years. So all those kind of things need time. And then this is just a slide to show that in this study where we only found 44% improvement on the milk-free and 40% on the 41% on the 4-food elimination diet. So clinically, we had the same level of improvement on 1 versus 4. Quality of life was much better in the 1-food exclusion. So again, sometimes it's not just about the food and the allergens, but you know, can the family actually cope with it? This is my favorite slide. So again, this friend of mine in Holland, I've been saying to her for a long time, I wish somebody can look at the immodulatory components in food and whether that affects eosinophil counts. So this is really a rough and ready study, and it was only published as a letter, and we can do way better than this in nutritional research. But what they did do was they looked at what the patients ate and the eosinophil counts, and then what they found was that they had reduced counts. So it was a positive thing to eat rice, pasta, iron, fiber, soy, magnesium, vegetables, and yogurt, no surprise. And they saw increased eosinophil counts if the patients were having more, sorry, let me just, next, I need to keep going. Okay, sorry, now I'm too bad, previous. That the patients had increased eosinophil counts, so it was a negative outcome if they had more phosphorus, B12, meat, sunflower oil, hence my question about the canola oil, stir-fry oil, and a lot of fat. So again, we need much better studies, but once again, just demonstrating it's not just about the allergens, because all these patients were on a 4-food exclusion diet, but the foods that they chose were different in those components, and we had better eosinophil counts in the group where more pasta and rice and iron and yogurt. So this is just one slide really just to remind me to say that, you know, the esophageal microbiome looks very different from the gut microbiome. We have 2 studies ever that's looked at the esophageal microbiome. We know from this study that if you change the diet, so this was before 6-food, this is after 6-food, the microbial diversity in the esophagus came down completely. Now we would think that's a bad thing because we want more diversity, but as the esophageal microbiome diversity came down, toll-like receptors came down, and so which is a good indication that the innate immune system have just calmed down. So we need to understand a lot more about the esophageal microbiome, but as much as we believe that diversity in the gut is a good thing, diversity in the esophagus may or may not be a good thing. Diversity in the lungs, ear and nose is definitely not a good thing. If you have more microbial diversities in the lung, ears and nose, it's an indication of inflammation. So we really need to learn a lot more about the microbiome in all the different body sites. This is just my study. This is unfortunately adults. I haven't got something similar to show you in children, but just showing you that if we look at diet quality, this patient ate very low amounts of fruit prior to the 6-food elimination diet and then increased it a little bit. This person made no change on their fruit and vegetable intake, had a lot of convenience food at the beginning, a low amount of convenient foods, the same for processed meats, and so we can go through. So again, just a note for us as dietitians that when we see the patients, talk about, you know, commercially available foods. I'm going to show you a few slides now. I am guilty. I do recommend it on occasion for my patients, but if we can home cook as much as possible, we're probably better off. This is not just kids with EOE, but this is a paper I recently published with Roseanne Meyer and Hannah Hunter. We looked at children with food allergies across the world, and you can see here, as I say, the Americans never let us down. We have a good height for age, we have a good weight for age, we have a weight for height, we have a good weight for age. So not all children with food allergies are stunted and skinny. I never had EOE, but this is me. But we have to look at the patients, which is again, and somebody said this morning earlier, just because they may be overweight and tall doesn't mean they don't have malnutrition. So we really have to look at the bigger picture. And this is why I say to the doctors, and I just said it to Dr. Atkins again last night, we need to see these kids on steroids as well, even if they opt not to go for a 6-food or 1-food or 4-food elimination diet, because we need to know what they're eating. And perhaps now that they're on steroids and they can swallow, we can make that diet that they're going to pick something better than bacon and burgers and chicken nuggets. Because actually, I tell you, for some of these kids, being able to swallow a chicken nugget is the best thing that's ever happened to them. And perhaps we can say, okay, 4 weeks of chicken nuggets, and then this is where it stops. So also elemental formula, this is not something that's come up, but in the food allergy world, and if you've ever heard any of my cow's milk allergy talks, this is another paper I published with Kiran and Roseanne Meyer. You will see that if you want a kid to catch up growth, elemental diet do way better than extensively hydrolyzed formulas. So what we see in the EOE studies is we take the kids off food, we put them on elemental diets. You'd think now they're not going to grow because, they have no food. But actually, their growth catch up. So just another sign point perhaps today for you, if you put a kid on a 6 or 1 food exclusion diet and you're concerned about the growth, put them on a supplementary elemental formula because it does help very well with catch-up growth. So in the clinic, I'm no idea about time, so you have to wave or ring the bell of shame. We talk about reading food labels. We talk about hidden allergens in food. This is my other classic story about EOE, and I'm sure Dr. Atkins can say the same. We have patients that responded on a milk-free diet that go and cheat, and they have pizza over weekend. But they come back and their endoscopy is clean. Then I have other patients where the mom swears blind. The only contamination they have was that she cut some cucumber on the same chopping board as the other kid grated the cheese on, and that level of contamination caused the endoscopy not to be clean. I think what we can take is there's also a spectrum of tolerance in EOE, as we see in FBIS, as we see in IgE food allergy. But to study this in EOE, I mean really, who's going to make a kid eat trace amounts of milk for 12 weeks? Just to put a scope down and see what happens. So we don't know, but I think we're confident to say we're beginning to learn there's definitely a spectrum of tolerance. We talk about suitable replacement foods, nutritional adequacy. So as dietitians, I think the main thing is really that written resources. When I do an FBIS consultation, I keep it very simple. I tell them what they can eat. When I do an EOE consultation, I give them 6 pages of written information about what to avoid, suitable substitutes. It's a very different consultation to have. I love online resources. Oh my goodness, the internet and Children's Colorado is so slow, it drives me insane. But I spend a lot of time showing patients websites. There's just 2, but if anybody of you want a longer list, I'm very happy to send it to you. Recipes, suitable products, that kind of thing. Elemental diet, just getting back to the Crohn's disease talk, pain of my life. These kids can eat anything without protein, okay? So they can have candy, such as dum-dum lollipops, rock candy, cotton candy, Smarties, Fun Dips, and Pixie Sticks, because it's the only thing they can eat. As a dietitian, it breaks my heart, but it's either that or nothing. And Smarties in Europe, made by Nestle, is actually chocolate candy. So the first time I was in EOE clinic in Cincinnati and that doctor told the kids they can eat Smarties, I thought, no, you've really lost it. This is why you need a dietitian in clinic. But I've come to realize that the Smarties in this country is just artificial color and sugar. So I do recommend these milks. They probably all have soy lecithin or something in, but you know, this is just something they can take in a lunchbox, other than something that says Nucate or Elemental, whatever on it. I apologize, I didn't mean to hit on Nucate. You know, cheesy mac. Every kid in America wants to eat mac and cheese, other than my kids, because they say they don't know what that yellow stuff is on their macaroni, because they didn't grow up in this country. But most American kids, and yet they can go to a sleepover, and they can also take something out of a packet. When everybody calls and get junk food, they have some junk food too. It just normalized life a little bit. Coconut yogurt you can buy. I've published data, I'm not showing you today, but if kids avoided cow's milk for the first year of their life, they never actually prefer to eat ice cream, chocolate candy, yogurts, and cheese, because they've never had those textures. So if you can give them something of a similar texture that's milk-free for future, then that's important too. And then, you know, in this country, everybody wants to eat a PBJ sandwich. They can have sunflower seed butter. I'm dreading to think which emulsifiers are in those dairy-free spreads, but they can have that, and they can have some cream cheese, you know. And then this is just ready-made pizzas, so they can go to a teenage sleepover party and they have their own pizza in a box, you know. Perhaps it's not something I'd like them to have at home ever, but for that night, they can be just like the rest. And then we talk about monitoring. I don't want to go into that. This is a slide on its side to say, do we start small? Do we start with milk and build it up to 6, or do we start at 6 and come down? That's really a discussion for the whole family, the allergist, and it's not something we can decide in 5 minutes, and there's no evidence really to tell us which one is best. This is just for the dietitians, a study I did in the US. Moms don't just want dietary information from us. They want us to help normalize life. They may help us to get the kid to be a little bit more independent. They need us to teach them to become an expert. They want the kid to be healthy. They want the kid to be independent. They need somebody to advocate for them, and also that bit of emotional support. We are not psychologists or counselors, but we can be there for them. And so this is my final slide. If you are a dietitian, or if you don't have a dietitian in clinic, this is a beautiful paper. Dr. Atkins is one of the co-authors too, which we did with lots and lots of handy handouts in the appendices. So you never have to write a 6-food elimination diet handout ever. You can just download it from the website. Thank you.
Thank you.